Imagine you're just standing in this chaotic emergency room, right? Alarms are ringing everywhere, medical staff are rushing past, and someone hands you this tiny, flimsy little slip of paper.
Yeah, just a basic printout from a machine.
Exactly, just a printout with a few numbers on it. But, I mean, if you know how to read it correctly, that little receipt tells you the exact story of a patient's breathing, their cellular metabolism, and this is wild, it even unmasks hidden poison circulating in their blood.
It really does. And the most incredible part is that you can decode that entire story in, under 90 seconds?
Right. So today, we are going on a mission. We're taking a deep dive into a stack of critical care protocols, clinical case studies, and advanced diagnostic literature all about decoding arterial blood gases, or ABGs.
It's basically a masterclass on reading the chemistry of breathing.
Yeah, we're going to break down this systematic, totally bulletproof method for reading that chemistry. So whether you work in critical care or you're just endlessly fascinated by human biology, this is really about how to see those invisible forces keeping us alive.
Absolutely. And to set the baseline for this entire discussion, you really have to understand that the human body is just completely obsessed with one thing, and that's keeping the blood pH perfectly balanced at 7.4.
Which is pretty specific.
Very specific. It is a non-negotiable target. I mean, everything. Your enzymes, the electrical conduction of your heart, your brain function, it all relies on that exact number to operate.
Wow.
Yeah, if it shifts too far, your cellular machinery literally starts to denature and shut down.
Okay, let's unpack this. Or wait, I shouldn't say ... but you get what I mean. Let's unpack this, because the body doesn't just sit around and hope for the best, right? It actively uses these two main dials to constantly adjust and defend that 7.4 TH.
That's a great way to look at it.
I was thinking about this like a home heating system, actually. You've got the lungs, which act kind of like a quick little electric space heater, you know. They control carbon dioxide, or CO₂, which basically functions as an acid in the blood.
Right, and the lungs can adjust that acid level in a matter of minutes just by changing how fast or how deep you breathe. They are your rapid response team.
But the underlying cellular metabolism is complex, so you need a second, I guess, more robust dial, which would be the kidneys.
Exactly. If the lungs are the space heater, the kidneys are like radiant floor heating.
Radiant floor heating, yeah, that takes forever to warm up.
Precisely. They control bicarbonate, or HCO₃, which is a base. And the kidneys are slow. I mean, they take days to synthesize new bicarbonate and excrete hydrogen ions to actually make meaningful adjustments to the blood chemistry.
So you have the fast acid dial, the lungs, and the slow base dial, the kidneys. And looking at the medical protocols, they highlight 3 anchor numbers we need to memorize to read this whole system.
Right, the anchors.
Yeah, so our perfect blood pH is 7.4A,
Yeah.
Our perfect CO₂ level is 40, and our perfect bicarbonate is 24. I assume any deviation from these anchors is the body screaming that something is wrong.
It is, which brings us to the very first hurdle. Because before you even attempt to look at those numbers to form a diagnosis, you have to validate the sample.
Right, because a bad sample is dangerous.
Incredibly dangerous. A technically flawed blood gas reading, delivered with authority, can lead you completely astray. The clinical literature heavily warns about things like microscopic air bubbles left in the syringe.
Wait, I need to ask about that. Why would a tiny air bubble change the actual chemistry of the blood sample sitting in a plastic syringe?
Well, it comes down to the basic physics of gas exchange. So warm air has almost 0 carbon dioxide and about 21% oxygen.
Okay.
And gases always move from areas of high concentration to low concentration. So if an air bubble just sits in that syringe, the oxygen from the bubble rushes into the blood, and the CO₂ from the blood escapes into the bubble.
Oh, wow.
Yeah, the sample basically equilibrates with the room. Suddenly, the printout shows high oxygen and low CO₂.
Meaning, you might look at that paper and confidently diagnose a respiratory issue that doesn't actually exist in the patient.
Exactly. You're treating the room air, not the patient.
That's terrifying.
Yeah.
And the literature also warns about a delay in getting the sample to the lab, right? Because the live cells in the blood, like the white blood cells, the young red blood cells, they keep metabolizing while just sitting in the tube.
Right. They will literally eat up the oxygen and pump out CO₂ while just sitting on the counter. And you also have to verify it is actually arterial blood.
Because if the blood gas shows very low oxygen, but the pulse oximeter on the patient's finger says they're fine,
then the person drawing the blood probably hit a vein instead of an artery, yeah. Arterial blood is post-lungs, it's heading to the body, so it should be super rich in oxygen. Venous blood is returning from the body, totally depleted of oxygen. Mixing that up completely changes your diagnostic picture.
Okay, so assuming we avoid all those traps and we have a valid sample, the next logical move is reading the pH to see which side of 7.40 we're on, right?
Right. Step 2. Less than 7.35 is acidemia. Greater than 7.45 is alkalemia.
But wait, I have to push back on something here. If I look at the paper and I see a perfectly normal pH of 7.4, I can't just assume the patient is fine.
What's fascinating here is that a perfectly normal pH is often the most dangerous kind of result.
Really? How so?
Well, a normal pH with abnormal CO2 and bicarbonate numbers does not mean the patient is healthy. It usually means you have two severe, totally opposing diseases trapped in a massive tug of war, perfectly masking each other.
Oh, man.
Yeah, we always have to lean toward the side of 7.4 that the pH sits on, but a dead center 7.4 when the other dials are spinning. That is a huge red flag that we are dealing with multiple crises at once.
That is wild, because we are so conditioned to just think, normal equals safe. So before we can treat a disease, we really have to interrogate the machinery controlling the chemistry.
Absolutely.
So now that we know the two dials, the lungs and the kidneys, how do we actually know which one is broken and which one is just trying to fix the problem?
The rule for naming the culprit is beautifully simple, actually. The dial that moved in the direction that explains the pH shift is your primary disorder.
Okay, let me make sure I'm visualizing this right. If the blood is acidic, meaning the pH is low, and I look at the CO2 dial and it's super high, well, CO2 is an acid.
Correct.
So the high CO2 perfectly explains the acidic blood. The lungs are holding on to acid, meaning the lungs are the culprit. That would be a respiratory acidosis, like maybe the patient has severe asthma and physically can't exhale the CO2 out.
You nailed it. And conversely, if the blood is acidic, but you look at the bicarbonate dial and it's really low, that means the body lost its pace.
So the kidneys or the metabolic system is the culprit.
Exactly. That is a metabolic acidosis, which could be from kidney failure or a severe infection flooding the blood with acid that just destroys the bicarbonate.
Finding the primary culprit makes a lot of sense. But the body doesn't just surrender, which brings us to the concept of compensation. I kind of call this the body's homework.
Homework, I like that.
Yeah, like if the lungs fail, the kidneys try to step up and do the homework and vice versa. But there are limits to this rescue mission, right? The Medical Masterclass calls them the 2 iron laws of compensation.
These laws are absolute cornerstones of critical care. Law number 1, the body never overshoots the 7.40 pH mark. And law number 2, it never fully normalizes it either.
So what does this all mean? I was picturing physiological compensation like a thick rubber band.
Okay, go on.
If a disease pulls your pH down into the acidic danger zone, the other healthy organ system acts like a rubber band, stretching to pull the pH back up toward normal. It can stretch to help, but it can never snap all the way back to a perfect resting state of 7.40 on its own.
That's spot on. It will get close, maybe 7.36, but never 7.4. And it definitely won't fling you all the way over into alkalemia.
And if that rubber band actually snaps you all the way back to 7.4,
then you aren't looking at heroic compensation anymore. You're looking at a second, entirely separate disease pulling from the opposite side. This mathematical certainty is why we can't just rely on our gut feelings in the emergency room.
let's ground this in a real clinical example. So it's 11 p.m. You get a 62-year-old patient with COPD, chronic obstructive pulmonary disease.
A very common presentation.
He was admitted earlier for a chest infection, and now he is drowsy, confused, and really hard to wake up. The intern hands you his blood gas. The pH is 7.25, the CO2 is 70, and the bicarbonate is 30.
Okay, let's let the physiology speak here. The pH is 7.25. That is clear acidemia.
Yeah, that makes.
Then we look at the CO2 dial. It's 70, which is significantly higher than the normal 40. High CO2 is an acid, so that explains the 7.25 pH perfectly. We have our primary culprit, which is respiratory acidosis.
So the lungs are failing. But then we look at the bicarbonate to check the compensation homework. The bicarb is 30, which is higher than the normal 24. The kidneys are clearly holding on to base to try and fight the rising lung acid. But is it enough?
This is exactly where we rely on the strict arithmetic of those iron laws. For a chronic lung patient whose CO2 has slowly climbed to 70 over several years, the kidneys have had plenty of time, remember. They are the slow radiant floor heating to push the bicarbonate up to around 34, 36 to compensate.
But this patient's bicarbonate is only 30.
Exactly. The kidneys haven't caught up to this new acid load.
Meaning this isn't just his everyday COPD baseline. This is an acute on chronic emergency. His chest infection just rapidly spiked his CO₂ today, and his slow kidneys haven't had the days required to respond to this sudden attack.
Which completely dictates your exact treatment. His drowsiness is a condition called CO₂ narcosis.
That sounds bad.
It is. The carbon dioxide is crossing the blood-brain barrier, turning the fluid around his brain acidic, but because the math tells us this is an acute spike, we know we need to put him on a BiPAP machine, controlled pressure with a tight mask to physically help him blow off that trapped CO₂.
And crucially, we do not just blast him with uncontrolled oxygen, right? I read that if you give a chronic lung patient too much pure oxygen, you can actually suppress their biological drive to breathe.
That is a critical point. Their body relies on low oxygen to trigger a breath, rather than high CO₂ like the rest of us.
So if you flood them with oxygen, they stop breathing as deeply, they trap even more CO₂, and things get much worse. It's crazy that all of that incredibly complex medical decision-making comes from a 90-second read of that tiny slip of paper.
It really is.
Right.
But the clinical literature emphasizes that sometimes looking at just the lungs and the kidneys isn't enough. Sometimes there is a third, totally invisible player in the blood.
The rogue acid, which means we have to go hunting for the mathematical void, right? The Anion gap.
Yes. This tool separates simple pattern readers from actual diagnostic interpreters. Every single time you identify a metabolic acidosis, you must calculate the Anion gap.
And the formula is beautifully simple, right? It is just your sodium level minus the sum of your chloride and your bicarbonate.
Correct, because sodium is positively charged, while chloride and bicarbonate are negatively charged.
Usually when you subtract the negatives from the positives, you have a small, completely normal leftover gap of about 8 to 12.
Right, that's just baseline unmeasured ions.
But if that gap is suddenly massive, say it's 25, it means an unmeasured, invisible acid has invaded the bloodstream and literally evicted the bicarbonate to take its place.
Exactly. Bicarbonate had to be spent molecule for molecule to neutralize this invisible invader. And to figure out who the invader is, the medical community uses the acronym GOLDMARK.
GOLDMARK.
Oh.
You're listening right now, you definitely don't need to memorize the whole list, but some of these are wild. The G stands for glycols, like antifreeze.
Yeah, people actually ingest it, and it floods the body with a lethal, unmeasured acid.
And the M is methanol, which you find in bad bootleg alcohol.
But the L is the one that keeps ICU doctors awake at night. L-lactate.
Oh, lactic acid.
Right. When a patient goes into severe shock or massive sepsis, their cells stop receiving enough oxygen. To survive, the cells switch to a backup emergency energy system that produces lactic acid as a byproduct. It's a massive, life-threatening red flag.
But there's a huge trap here that the protocols warn trips up even seasoned doctors. You have to correct the gap for albumin.
Yes. Albumin is a protein, and it naturally serves as the biggest unmeasured negative ion in our blood. It essentially makes up the baseline of that normal 8 to 12 gap.
Here's where it gets really interesting. If a patient is severely malnourished or has liver disease, their albumin levels just crash. The rule from the masterclass is that you have to artificially add 2.5 back to your mathematical gap for every 1 gram drop in albumin below normal.
That's the correction factor, yes.
So let me ask you this. If a doctor forgets to correct for low albumin in a sick, malnourished ICU patient, could they look at a completely normal gap on paper and completely miss a massive, life-threatening lactic acidosis?
If we connect this to the bigger picture, this is a terrifying daily reality in intensive care units. In a septic patient, their albumin is often sitting in the basement.
Wow.
Because that baseline protein is gone, the gap shrinks. If you don't manually add that math back in, the gap you read on the printout is literally a lie.
It'll just look perfectly fine.
It will look perfectly normal at 10 or 12, giving you a false sense of security. Meanwhile, the patient is in profound shock, and their cells are drowning in unmeasured lactic acid. You always, always correct for albumin.
Wow. Okay, so we've found the invisible acids. We've corrected for the missing proteins. But what if the patient is suffering from 3 different metabolic emergencies at the exact same time? How could we possibly untangle that?
By checking to see if the medical bookkeeping is honest, we use the delta ratio.
The delta ratio. I found the best way to visualize this is to imagine your body's bicarbonate is a bank account balance. And the hidden acid we just found in the Anion gap is like an unexpected withdrawal.
That is a brilliant way to frame it, because the human body operates on a strict 1-to-1 exchange rate. Every unit of new rogue acid should cost the body exactly 1 unit of bicarbonate to neutralize it.
So if the acid takes out 10 units, Your bicarb balance should be exactly 10 units lower.
Exactly.
But if I look at the math and the delta ratio is completely skewed, say, my bicarb jaw count is only 5 units lower despite a 10-unit acid attack. That means the bicarbonate didn't fall as much as it should have, or it's artificially high.
Which means someone else has been secretly depositing base into the system. You have a massive high-gap acidosis from the invisible invader, but you also have a completely separate, hidden metabolic alkalosis pumping base into the blood.
Like a diabetic patient suffering from severe ketoacidosis, which is a huge invisible acid attack.
Right.
But they have also been violently vomiting for 2 days.
Right.
Vomiting aggressively dumps stomach acid out of the body, which ironically leaves behind a massive buildup of base in the blood. So you have 2 totally different life-threatening crises perfectly masking each other.
And if you just looked at the bicarbonate in isolation, it might look deceptively normal. The delta ratio exposes the lie.
Which perfectly sets up the most chilling case study in the entire clinical literature we are reviewing.
The opening case.
Yeah. A 24-year-old woman is brought into the emergency room. She is drowsy, found next to an empty strip of tablets. Her ears are ringing and she is breathing incredibly fast and deep.
And the intern reads her arterial blood gas. Her pH is 7.41, basically perfect. The CO₂ is 20, and the bicarbonate is 12.
And the intern looks at that 7.41 pH and confidently declares she's compensating well.
This raises an important question about how our medical intuition often fails exactly where strict systematic arithmetic succeeds. Human intuition sees a 7.41 pH and assumes safety.
But look at the rules of the system. Her CO₂ is 20, which is half of normal. Her bicarb is 12, which is half of normal. Both dials are violently spinning.
And remember the iron law of compensation? The body never, ever fully normalizes the pH.
So that 7.41 is not heroic rubber band compensation. It is a physiological war zone. If you actually take the time to calculate her anion gap, it is a massive 26.
She swallowed the whole strip of aspirin. This is profound salicylic poisoning.
Oh man, aspirin.
Yeah, aspirin is uniquely diabolical as a toxin. First, it floods the blood with a massive high-gap metabolic acidosis, but simultaneously, it easily crosses the blood-brain barrier, gets into the brainstem, and directly whips the medullary respiratory center.
So it's forcing the brain to trigger rapid deep breathing.
Exactly. This causes a primary respiratory alkalosis.
2 lethal diseases, pushing with equal and opposite force. The massive acid from the pills and the massive base from the hyperventilation, leaving the surface pH sitting pretty at 7.41.
It's terrifying.
Think about how easy it would be to look at that 7.41 and just walk away. Or even more terrifyingly, to look at how fast she's breathing, assume she's just tiring out or having a panic attack, and decide to sedate and intubate her to, take over her breathing.
If the medical team had casually intubated her, they would have set the ventilator to a normal breathing rate. The absolute second they stopped her from hyperventilating, that respiratory alkalosis would vanish.
Leaving the acid unopposed.
Exactly. The massive aspirin acidosis would suddenly be completely unopposed in her blood. Her pH would have crashed through the floor in a matter of minutes, causing total cardiovascular collapse. It would have been instantly fatal.
The intern's remark, "She's compensating well," would have been a fatal compliment. Her frantic, fast breathing was the only physiological mechanism keeping the poison out of her brain. If you're listening right now, just pause and think about the gravity of that.
It emphasizes why we rely on the algorithms of physiology. It is about letting the biological data speak for itself, rather than forcing a convenient, surface-level narrative onto it.
Reading an ABG is clearly not about guessing. It is a strict, undeniable script. You validate the sample so you aren't tricked by room air bubbles. You read the dials, the fast lungs versus the slow kidneys. You check the body's compensation homework, mathematically ensuring it follows the iron laws. And then you hunt for the hidden poisons using the anion gap and the delta ratio.
It strips away all the chaos of the emergency room and forces you to confront the absolute truth of what is happening at a cellular level.
And for you listening, whether you are a medical professional running an intensive care unit or just someone fascinated by how fiercely resilient the human body is, the lesson here extends far beyond medicine. It is about the vital importance of trusting a robust mathematical system over quick, surface-level intuition. A seemingly perfect surface, like a 7.4 pH, can hide a chaotic war underneath.
It forces us to entirely rethink our definition of normal. Normal isn't always peace. Sometimes normal is just a perfectly balanced standoff between 2 destructive forces.
And that leaves me with a final thought for you to mull over. If our own blood chemistry can maintain such a deceptive illusion of normalcy by perfectly balancing a lethal acid with a lethal base, What other complex systems in our world, be it our climate, our global economy, or even our own mental health, are currently registering as normal, only because two catastrophic forces are temporarily masking each other? The next time you look at a surface that seems perfectly calm, well, just remember that flimsy slip of paper.
That completes the ABG Master Course. If you found this masterclass useful, consider subscribing to Clinical Horizon for more evidence-based internal medicine teaching, clinical cases, and exam-oriented reviews. Thank you for listening.